Okay. Hello again, welcome back. I hope everyone's feeling recharged. The afternoon will continue to deliver some exciting content, all of which will be available to view on demand within 24 to 48 hours. So don't worry if you've missed anything earlier. In this panel, we'll be discussing the role elective treatment has in relieving pressure in the NHS. Despite extraordinary and unprecedented pressure throughout the pandemic, the NHS delivered more than 23 million experiences of elective care, 36 million diagnostic tests, 4.2 million urgent cancer tests, giving more than 530,000 first treatments for cancer. With these incredible achievements, though, the pandemic has, of course, taken its toll on the amount of planned care across the entire health service, as the patient waiting list gets longer. The NHS will focus on 4 areas which will help ease the ever-growing problem of the backlog. These include increasing health service capacity, prioritising diagnosis and treatment, transforming the way we provide elective care, and providing better information and support to patients. This nationwide plan will require a reliable focus to ensure these objectives can be met at all levels. To support this elective recovery, the government is planning to invest £8 billion for 2022 and 23 and 2024-25, supported by £5.9 billion in capital investment for beds and equipment. So let's welcome for our discussion this afternoon, Dr. Mark Ratnaraja, Managing Director at C2AI, Amanda Sullivan, Executive of Nottingham and Nottinghamshire ICS, and Imran Ahmed, Consultant Anaesthetist and Deputy Director of Theatres for Guy's and Thomas's NHS Foundation Trust. So do remember to submit your questions if you have any. It also helps me if you say who the question's for, and you'll find the Q&A on the right-hand side of your screen. So I have to put my glasses on so I can see who I've got, and we've got you, which is fantastic. Welcome to you all. Imran, can we start off with you, if may, Guy's and St Thomas's? Why do we have such a big waiting list backlog? It sounds a basic question, but it would be interesting to hear your answer.
Thanks, Helen. I think it's a combination of reasons. Obviously, you've mentioned the pandemic, and lots of change since the pandemic. We couldn't operate during the first surge and the second surge, and since then, the reset has probably affected theatre efficiency and not really been able to get as many cases as we used to pre-pandemic date, and the data suggests that we're way behind what we were doing. Pre-pandemic, even though at that time we thought we weren't maybe doing as well as we could have, but now looking back, actually we were doing quite well compared to what we're doing now. I think there's a combination of reasons of why we're not as efficient as we used to. There was all during the pandemic period, and there was a lot of issues with the patients testing and isolation periods and staffing numbers being a lot lower than normal. And then sort of since then, as we're recovering, just find that everything takes a bit longer. We have sort of more cancellations. We struggle to get through the numbers as we were before. And so when you have a backlog already, and you need to probably do 2, 4, 10% more than we were doing before, that compounds the problem, and it's just worse and worse. So I think it's a combination of reasons, but theatre efficiency is one of them that really does seem to make a difference to us getting through cases.
And Imran, how frustrating was it for you and your surgical colleagues during the pandemic? I mean, presumably at one stage theatres were empty, were they?
Yeah, so I'm an anaesthetist by trade, and from an anaesthetic perspective, we were actually busy. We were sort of running intubation teams. We were helping critical care. We would open sort of critical care areas within our recovery, within our theatre space. So anaesthetists and anaesthetic staff and theatre staff were actually quite busy. But since then, it has been frustrating because there are just lots of different reasons why we just can't get through the numbers that we want to. And that's when we sort of started innovative ideas like the high intensity theatre list, like trying to improve theatre efficiency, looking at different aspects of the patient pathway and trying to improve on those to reduce the number of delays and cancellations, just trying to get through as many cases as possible. So yeah, it's very, very frustrating to see that, but actually the staff have been working very hard. but in different areas, which has coming out of the pandemic into the recovery, and the staff are all quite tired and have been non-stop throughout that whole period.
Oh, I can imagine. Hold that thought on innovative ideas, because it'd be interesting in the discussion to find out exactly what you're doing. Let's bring it into the conversation. Mark, how can data help? What is the role of data in trying to reduce this pressure being experienced at the moment in the NHS?
Well, Imran's given a good example of innovative working and the pressures on clinical staff working in hospitals. But what underlies a lot of this is a change in demand that is occurring. Patients are getting sicker, they're presenting later, and they're being ordered onto the patient waiting list far later than they would be anticipated to normally. And of course, the waiting list was getting longer even prior to the pandemic, and the issues faced with dealing with surgeons in COVID-19 have just exacerbated those problems. A lot of evidence suggests that actually patients are getting sicker while waiting, A, because they're waiting for longer, but B, because of their underlying physiology and indeed their comorbidities. And certainly there's a lot of evidence to suggest that frailty, mobility and comorbidities have all got worse, either because of a lack of access or because of that delay in having their intervention. And of course, once they present, it therefore means their operations can be more complex, or indeed they present as an emergency, which therefore means that they're actually having to have a much more protracted course of treatment and unplanned admission to ICU. And so the data that really is there to try to understand what's happening in that very long tail that's sort of occurring. But importantly, it really needs to identify what's happening in a dynamic way. I think one of the challenges that we have is there's no shortage of data. It's just that often it's siloed. It's not communicated well between different stakeholder groups, between primary care, secondary care. Of course, we're not necessarily intervening in that pathway of care. We're resorting to the current paradigm in terms of how we treat patients based on what we were doing pre-pandemic. And of course, the world has changed and the needs of those patients have changed. And we understand sort of dynamic demand management is an important part of being able to then do something about it, which includes things like prehabilitation, anticipatory pathways, and so on. So data plays a big role, but it's being able to use it in a proactive way.
Use it properly. And there's a picture of Nottinghamshire ICS. What sort of problems have you encountered, and have you found has been helping where you are?
Thank you. So yeah, I think much the same as has been described. We were doing very well in terms of waiting lists, but we have found that we had to divert staff into dealing with the pandemic. And then we've also found that whilst hospitals remain very busy and still have sort of patients in them, that has meant we've had to work out how the patients can be safely cared for, making sure they're not contracting in either COVID or flu in the hospital. So that restricts the way that you can use the systems and the way that you can use the capacity to do the operations. So we have seen similar things, and we again doing a lot to try and increase the volumes of people that are able to safely have their treatment or their diagnosis in the hospital and reduce the waiting as far as possible. We've been really tackling that from two ends. One, in terms of the most clinically urgent and the things that are most time critical, such as cancer surgery, and making sure that can be done in a timely way, but also where people have been waiting a very long time, to give them some priority as well. So we've been in those two areas.
I don't view balance, because it must be very difficult to get it right. And, obviously cancer patients need prioritising, but there are lots of other conditions as well that, people are suffering badly with. So it must be very difficult. And in your area, Amanda, do you feel that you make really good use of data? Mark was saying that data is great, isn't it? But it's got to be used properly. But do you really rely on it and have found some, efficient ways to use the information well and to your advantage?
Yes, we've got a lot more data now, and I thought it was very interesting what Mark was saying about the additional complexity of people as they wait longer for their treatment, and certainly our social care services, their demand has gone up hugely because of people waiting and becoming more frail and ill and needing support to manage at home just because of the backlog. So that has had an impact not only on the NHS but on social care as well. So one of the things that we are doing is working across the whole system to share that information so that we can be as fair as possible to people and giving them access to hospital treatment. And so we're looking at 2 different hospital trusts in the area, and they are working very much together, treating it effectively as one waiting list and working out the priorities for treatment to be as fair as possible. So that's one area. And also working more with GPs, primary care, again, Mark's to try and prevent people and needing that treatment, but also to help people keep as well as possible, as well informed as possible while they are waiting for their treatment as well. So that working across with GPs, hospital teams and social care is really important to get the best possible information and care for people and to get the fairest access to treatment.
GPs things, music to my ears. I know across the country that's been negative from the pandemic. It's so difficult to get a GP appointment now, and then you see people who can't get to the GP clogging up A&E, and you know this needs to be a bit of a sea change there. But that's a whole different panel discussion. Imran, you teased us there with innovative ideas. What initiatives have you worked on at St Thomas's to try and deal with the waiting list? You know, inspire us with some of the things you're doing where you are.
Yeah, thanks. Thanks for the opportunity. We devised something called hit lists, high intensity theatre lists. And what we realized that the cases that we were doing were the sort of the higher risks of cancer cases, and quite rightly, we tried to get through as many of those as possible. But for patients who were non-cancer, you know, who needed hip replacements or hernia surgery or spine injections, you know, more sort of considered more minor procedures, not done because there was no place or time for them to be done. And so what we did was we thought of a different way of working and to work in addition to what was happening. So we looked at weekend work, we looked at high turnaround complexity type cases like hernias and varicose veins, and we used a new model where we used multiple teams and 2 theatres. And instead of doing 3, 4, 5 cases on the list, which is what normally happens, by planning the list and by using 2 theatres and multiple staff, we would end up doing 25 or 30 cases. Wow. On a Saturday, and that started off sort of during the sort of second surge when everything is done. And that's progressed into us doing more and more complicated cases. And we've actually managed to do 20 hit lists so far and operates on over 350 patients across various specialities. And on average, we tend to do sort of 20 or 30 patients on a hit list per list. And it has a dent into the waiting list. And if you sort of multiply that across a specialty or multiple specialties, and actually it does seem to make a bit of a difference. So the hit list program is well in our hospital, and we're hoping to try and sort of progress that across to other hospitals and beyond GSTT.
Having just watched 19 seasons of the medical drama Grey's Anatomy, they did something with very similar with the Whipple. I still haven't got to grips yet with what a Whipple is, but they did that kind of thing where they just push lots of people through. So I'm wondering, can this be scaled up? You know, we always talk about collaboration at these conferences. Could these ideas go to other hospitals and scale it up, if you like?
Yeah, we hope so. So we've been in discussion with the Department of Health, with NHS England, with the GIRFT team. And what we're trying to do is trying to scale this beyond just our hospital. So if you could imagine 100 hospitals doing sort of 12, 30 hernias on a Saturday, you really can make a dent into the total waiting list. And if you do that across different specialties, different types of procedures, then you can really make a difference. And you do this in addition to on top of what's already happening. So during the week, you do your normal elective operating, and then you do lists on various weekends. And you can. I personally think that yes, you can make a big difference. And getting the policy holders and sort of people who are really interested quite high up within the NHS wanted to try and roll this out. We're working with them to try and deliver this beyond our hospital.
Yeah, fantastic. Mark, I bet that was interesting for you, was it, what Imran's doing with those the sort of hit things, if you like?
I mean, Imran's hit on sorry, the pun, but it is on a particularly interesting area, which is the focus of a lot of hospitals, quite rightly, is on cancer care path patients and P2 patients. But of course, what the P3s and P4s, many of whom are frail, some of them are elderly, particularly if you look at specialities like general surgery and orthopedics, many of them living with a high burden of comorbidity, which is getting worse because of a lack of access to primary and secondary care. And of course, these patients are getting worse as they wait. And so being able to identify them, use risk stratification to be able to identify these patients, particularly those who are at risk of deteriorating, and then profiling them and putting them in the right sorts of clinical scenarios, whether those be with lists, whether that be with the independent sector, whether that be with organisations or theatres that can manage that through that level of acuity is an important part of that. And to scale that up. So we've been doing a lot of work with surgical hubs across ICSs that are basically taking sort of the best of what's at a local level and then trying to apply that to pathways of care, whether it be based on particular specialities or particular theatre treatment types, in order to streamline processing patients and increasing the volume, particularly for the high volume low complexity work. It's a little bit of a misnomer because often some of those patients do have quite a degree of complexity, not necessarily related to surgery, but their underlying conditions. So being able to take that lesson, identify those patients early, and then apply that at scale is a critical step of being able to achieve a lower waiting list.
And I suspect that's really what you're trying to do as well, Amanda, isn't it?
It absolutely is, and one of the areas that we again have a hub, and we're trying to spread out those innovative ways of working, and also to make sure that we maximise the use of all the facilities. So we don't think about it as individual hospital waiting lists. We think about it as one waiting list for the whole system, and then we prioritise in that way with that clinical leadership that Mark described as well on that, and some different perspectives. So giving that perspective of whether people are deteriorating or how their priorities are changing. And the other big area is to really try and make sure that we keep people as involved in the decision making as possible, and to be aware of what the likely length of time is that they may have to wait. But we do find that if people get the right information right at the outset, probably even before they're referred to the hospital, that can really help people to make the choices about the right treatment for them. And sometimes people will opt, if there's different options that might not require surgery, people will sometimes try a more conservative treat first, perhaps some therapy or other things, depending. So, and that's really important, because what we don't want to do is have people go to, for example, their GP, and well-meaning that they set some expectations there that then are not fulfilled when people go and see specialists. So I think across the system, we try and make sure that people get as consistent information as possible to help them make the right choices for them as well, and repeated, opportunities to really think about what is going to be best for them with all their other health conditions as well, because obviously that will have an impact on the outcome. So that's really important.
So making them aware of the pros and cons and what options are available.
Absolutely.
Imran, what do you think to the idea of this kind of one waiting list? It sounds a really, really good idea to me.
Yeah, I mean that's essentially what we're trying to propose to the Department of Health by spreading this to various hubs of trusts, and then looking at maybe single specialties. So I mentioned hernias. Imagine about 160,000 hernias on the NHS wait list. Imagine if we all spent a week, or a month, just focusing on all is you could probably clear them within a year or two if you used hit this model, and then do that across various specialities. We're also looking at work, so using the possibly the ATL steps and doing the patient and looking at them from a regional perspective, not just a trust perspective. But Amanda and Mark have sort of raised important points about the pathway. You need to look at the whole patient pathway, and if you can make improvements on the whole patient pathway and tweak different aspects of it, then you can make a difference in terms of improving efficiency and choice, and also getting the patients operated in a safe and efficient way.
Mark, what do you think should be the role of integrated care and NHS England in trying to support all this recovery post-pandemic?
It's a good question, Helen. I think one of the challenges for individual trusts are a number of agenda. So they're dealing with the increased cost of wages. They're having to deal with winter pressures, dealing with increased inflation, and of course all of those things are a distraction to dealing with the burst, which is trying to get the elective recovery work up and running. I think where it has come in is being able to provide a clear agenda and strategy, particularly around the elective waiting list, and not just localities and regions, and also to some extent funding to make those things happen. Often activities follow the funding flows, and individuals are cost and time pressured to be able to do that on their own. And as Imran has said, actually you need to take this out to individual hospitals and start thinking about this from the perspective of specialities and pathways of care, and as has been touched on, being able to include primary care and social care into pathway design, so you've got a holistic roadmap for patients that they can follow. And we've seen, so we had some funding in Cheshire and Merseyside by NHS England and NHSX to support prehabilitation. We use risk stratification analysis to identify patients who are at risk and also identify their post-operative risk, and then flag those up for intensive remote health coaching alongside anaesthetic colleagues providing their preoperative assessment. And actually the outcomes of that have been excellent and indeed have resulted in an increased efficiency and throughput of patients, reduced demand on ICU, and in some cases converted inpatients into day cases, which ultimately means you can do more patients. From a patient's perspective, their engagement starts from the moment they're on board onto the waiting list, which means that to Imran and Amanda's point, they are engaged as part of that therapeutic journey. It increases their autonomy. Often it can be the gateway to dealing with chronic disease management. It's in the context of elective surgery. So there are lots of positives from this. It's about identifying these patients early, identifying what their risks are, and then building the pathway alongside that to accommodate this and intervene as early as possible in order to get better outcomes.
Just checking out some audience questions. Rangaraju says, Amanda, fantastic made by Amanda, but do you have a system that can be followed by all to have the shared decision making?
I think there are increasing tools and things that can be used. It does mean that clinicians and support workers do need some training, and that is in the time, but I think it is really important, and it can end up that people make the right choice at the outset and get a better expectation around what will happen as a result of the surgery and how much better they can feel or function in their everyday lives. And different people have different priorities. Some people will want hip replacements because they want or other things, and it just needs to be worked through with each individual. So there are definitely tools and bits of sort of quite visual things that help people think that through. But I think what practitioners would say is they need to make sure they've got training that happens across the whole pathway. But I think it is time very well spent, because it means people are able to make those choices and get onto the right treatment pathways for them.
How do you manage, Amanda, frustration and disappointment? I mean, whilst, everybody realises there has to be priority for certain things, diseases like cancer, but I'm thinking perhaps of somebody quite elderly who's hip replacement or or severe hernia that's impacting that person's life, not being able to spend time with their grandchildren or walk, and it's other health problems. How do you manage the expectation of patients and, you know, I suppose make them become, you know, understand that the NHS is in crisis and there is a wait? I would imagine that's quite difficult for you to do.
It is, and we're not in a situation that, you know, is an optimal situation. We would prefer that people didn't have to wait as long as they currently are, and we're working very hard to do that. I think some of that is making sure to keep people as informed as possible. And then the other things that we're doing very much with our primary care colleagues is in very local areas. There are some brilliant and really vibrant voluntary sector organisations, and sometimes to help people wait with, if you like, there's bits around helping them to get more healthy, manage their blood pressure and things, but there's also quite simple but really important things like helping people to connect out of the house, because otherwise people get increasingly isolated, and that has a negative impact on health. Thinking about health in its broadest sense, and again in our what we call primary care networks, working with the local councils, that is happening much more, and so people are able to go and connect with others, and that makes people's lives more fulfilled in quite difficult circumstances. So again, it's not the same fits everybody, but just helping people to keep social and active can be incredibly important.
Oh, it's so important. It's nice to hear the kind of effort you put in there. Imran, Jane says, we know different sectors of the community may receive longer waits. Has Guy's and St Thomas's considered this, and are they bringing people forward from deprived areas, for example?
Yeah, we've looked at how long they've been waiting for. Our catchment area is Southwark, which is deprived compared to sort of national figures, and we don't sort of pick patients according to that background, but what we're doing is we're looking at how long they've been waiting for. We're looking at patients who probably wouldn't get operated on, especially during the pandemic period, and bring them in so they get. So we did many patients who were having non-cancerous surgery who have been waiting for over a year. We managed to get them in by doing these extra hit lists. So we do try and target patients who wouldn't necessarily be operated on because of the effect of the pandemic, but also we're trying to do cancer cases as well. So we're looking at all types of lists, trying to benefit everybody. But just one little point I wanted to make, which in the centre of all of this are the patients, and obviously we're treated as quickly as possible. But for that to happen, we need to look at the well-being of the workforce. And they're a really sort of important part of this. So if the workforce are looked after and are sort of managed well, then they're more likely to be able to help the patients and get the cases done. So we've been doing a lot of work on incentivization, on well-being, to try and make sure that our workforce is able to help us get these hits underway and get the patients operate as quickly as possible.
That's getting a lot of little thumbs up emojis on my screen there. That's obviously resonated with a lot of our audience. And also Jane adds around PS, GST and Professor De Cruz's, she says in capital letters. So do pass that on to Professor De Cruz, if you would. Mark, we are kind of starting to run out of time, but I just wanted to ask, what lessons learned from implementing AI solutions in healthcare? I know that's an area that you specialise in, obviously.
Thank you. When we refer to AI, we refer to it with a small a, so we refer to it as augmented intelligence. And the reason I say that is that an important part of this is to ensure that the decision-making process remains sacred. The clinicians know patients well, and really what the technology there is to do is support them and enhance the level of knowledge that or rather insight that they have on their patients in order to make better decisions. So when we're doing our classification, we're using data from across the ICS. So that means that, let's say, a patient at a particular teaching hospital can see what's happening to patients in other regions if they would have been with an acute exacerbation of their underlying condition. And therefore, we can update on an ongoing basis their clinical requirements and their clinical necessity. And part of that also includes things like social determinants of health. So the AI that is really there to help in augment that clinical decision making, but be able to do that in real time and provide the clinicians with the details that they need in order to make an effective decision. We see this as replacing any of that, but really it's there to reduce the administrative burden, be able to do the prioritization on ongoing to see patients come in and old patients leave, and stop this sort of manual process of having to evaluate patients, which can sometimes be quite different depending on different departments and different hospitals, and provide some consistency to be able to do that all the way through that patient journey, in particular identifying patients at risk of deteriorating and presenting as an emergency. So it's really there as a decision support tool.
Got a message on the board from a member of the audience. Good point, Imran. Staff wellbeing. Much I'd like to carry on exploring all the different questions that still need asking. I think we are out of time, and I know we've got a keynote speaking up. So I'd like to say a massive thank you to Mark, Amanda and Imran. It's really good to have you on the panel today. Thank you for finding time out of what I know are busy schedules to join us. Thank you very much. Next up, we're going to hear from Mohammed Shabir, Head of Customer Success at Amwell. Many factors contribute to long wait times, and it's not just elective treatments which are affected, as we've heard today. The NHS faces many challenges as an employer, but it is offering the wellbeing support make it competitive at talent attraction and retention. Short-term decision-making can have negative long-term consequences. Could better decisions be made with better diagnostics offered by digital solutions? These questions and more will be answered by our events partner, Amwell. So, Mohammed, it's over to you.
Brilliant. Thank you. Hopefully you guys can hear me okay. And it was great to kind of pick up on some of the points just in the concluding session as well. And I think they're very much kind of hit home on some of the areas that I'll be focusing on today. So I'm Mohammed, Head of Customer Success here at Amwell, and our kind of flagship product, digital product used right throughout the NHS is Silver Cloud. Today I'll be talking very much about the NHS backlog, and in terms of what kind of coverage, what attention the mental health backlog actually gets, and some of the challenges that we face because as a nation and as a healthcare service there to deal with the mental health crisis that we have. On the next slide, please, you'll see some stats, which I think, will be all too familiar, not just kind of for the layperson, the general public, but certainly for NHS clinicians and services. So Mind data telling us 1 in 4 people will be experiencing a mental health problem in any given year. The Mental Health Foundation stats, which again, very striking, 15 million people who have a long-term physical health condition. Of them, 1 million also have a comorbid mental health condition. So there's comorbidity. There isn't the kind of the physical and the mental. You cannot kind of separate those out completely. They're intrinsically linked. There's been a lot, certainly kind of during the COVID pandemic and post-COVID pandemic, of adolescent and young people's mental health. 20% of young people, adolescents, experiencing some type of mental health condition throughout the year. And all this then kind of culminates in some of the data here that you'll see. 1.5 million people actually waiting for a mental health intervention. We know resources are always a challenge in the NHS. I myself, kind of as a mental health nurse, previously worked within the NHS. I kind of know that very clearly and seen that at the front line. And we know, and certainly the last 15 years in digital health, that problem isn't going away. It's actually getting worse. So on the next slide, I kind of want to kind of then steer the conversation now of what feedback we actually get from the NHS. So we've been operating in the NHS as a partner for kind of nearly kind of 10 to 15 years now. And we know the services that we work with, the IAP services, secondary care services, children and young people services. There's massive waiting lists that they're facing, and there's pressures in terms of targets to achieve and hit. And digital health, digital tools are one solution to kind of help alleviate that problem, because there's an expectation as well right now that people are are busy 24/7. You know, it is kind of our life, and people want access to services 24/7. The demand for mental health is going to rise, and it's not slowing down. Patients are obviously also frequently requesting digital and mental health, and it's very interesting because the stats now available. COVID, if you like, forced many of us to go digital when services down. So we saw a massive implosion of digital activity, access to digital services, digital appointments, and actually kind of post-COVID, we haven't seen the massive cliff drop. We're actually seeing patients still wanting to engage in that way because of the flexibility that it offers. But also the kind of the final point here is, you know, clinicians struggling to keep up with the pace, and the burnout is a major concern. I mean, these are points which kind of Imran just mentioned in the previous call. So it's kind of a nice little segue into that. You know, NHS mental health staff survey by Association of Clinical Psychologists, 44% of the respondents demonstrated and stated that they had unmanageable caseloads. And it comes back to that point of, if we look after the staff, and they'll be better able to run the services and also look after the patients whom we're there to serve. So the next section, if I can have the next slide, please, again, kind of focuses on the recruitment and retention. Again, follows that same topic of how does the NHS retain and recruit staff? And this is one of the key things. How do we not retain them, not just recruit them, sorry, but retain them? And how do we look after them so they can provide the quality of services that we want to deliver as clinicians, we want to deliver as services that patients expect as well. So on the next slide, please, you can see that, you know, having a digital mental health support place is really important for an employer. SilverCloud has worked with NHS to deliver services to patients, but it's also been very active in working with EAP providers who provide EAP support to NHS staff, who are also utilizing offers like SilverCloud. Again, offers great flexibility and 24/7 access. So the key thing there is, when people are looking for work, any job, be it NHS or non, everybody wants to attract the best talent. But what's important is to understand, what does the worker want? What is the worker looking for? Quite often, they're always looking, how can the employer help me? What are the benefits that my employer can bring me? One of the things that SilverCloud did during the COVID pandemic was actually provide SilverCloud wellbeing programs right across the country for all NHS staff across England, Wales, and over in Ireland as well. So having access to digital support, mental health and wellbeing support, does help attract talent, because it's a sign to the kind of employee that actually we care, as an employer, we care about you and your well-being. It supports our well-being with programs around sleep and stress. There's lots of great data that shows employee mental health initiatives reduce absenteeism and presenteeism. So when you're there, you're actually operating in the most effective way possible. And again, you know, happy employees make fewer mistakes, and they are more productive. And having 24/7 access to digital tools is definitely kind of a plus and a bonus. And right now, I'd say an essential component to any employer, including the NHS, to have available for its staff. On the next slide, and kind of in the next section, I'm going to briefly talk about diagnostics. And again, this was mentioned in the previous session. Having access to data is absolutely crucial to be able to deliver effective services. We're a data-led organization, the NHS. We use data to help us optimize our pathways and get the right treatment to the right people at the right time. And this is where collecting information digitally really helps us with that exercise. So on the next slide, you can see some of the diagnostics available within SilverCloud. We use many measures that are adopted by the NHS and the IAP services, questionnaires like PHQ-9 and GAD-7 around capturing baselines of how people are when they begin their intervention. These are repeated throughout the intervention in terms of session by session monitoring to allow clinicians and services to see how they're recovering. Do they need to be stepped up into another treatment? Are they ready for early discharge? So it really helps them optimize the service. So having solutions such as Silver Cloud and digital means and engaging with our patients in a digital way helps us collect this data in a very routine way without adding more burden on the clinician and without adding additional burden on our clients as well. So these can help us predict kind of how well people will do as well. And we have started to do some work as well in terms of kind of machine learning and AI, looking at some predictable around, you know, how long somebody's on Silver Cloud, what their scores on the PHQ-9 and GAD are, and actually how can that tell us whether they are potentially going to recover or not. And that helps us kind of change the clinician's position in terms of how they're supporting the client. What this kind of all culminates is into a very large data set. And that data set can be broken down in terms of the types of users, whether it's kind of gender, males, females, other genders, age ranges, socioeconomic background of people who are on the platform, to really give us an insight into who engages with these interventions best and how can we get them to those people, and those who don't engage so well with digital interventions, how can we improve the solution to make it much more accessible to them. And the great thing about data, and the NHS is very hot on this, and rightly so, is the fact that we can share data across systems. So our work within the NHS, we have integrations into the main case management systems in IAPT and in some secondary care as well, which means people don't have to log into multiple systems to get the data they need to make informed choices about their patients. On the next slide, I think it kind of follows on around that, about some of that kind of infrastructure that facilitates the digital delivery, certainly in mental health interventions. And NICE, for, I would say, the last 15 years have been absolutely amazing in terms of their review and their position on digital cognitive behavioral therapy. And there have been many success stories. So a lot of the guidelines, clinical guidelines for depression and anxiety, all encourage the use of computerized CBT, certainly for mild to moderate presentations. On the next slide, please, you can see that this infrastructure, this technical infrastructure, really allows us to reach people at scale. So there isn't the need to attend clinics. So there isn't kind of the need for estates facilities to actually see patients. Everything can be done remotely. I mentioned, obviously, the patient management systems that we're also integrated into, but also, you know, we have digital tools, you know, a part of face-to-face therapy as well. So there's the opportunity to have a very pure digital pathway with very little clinical support, to integrated tools into the face-to-face one-to-one therapy, to give clinicians the opportunity to also see how a client is working in terms of their treatment and their treatment approach. Next slide, please. So it comes back to kind of elective care, and there are a lot of themes which, you know, I've touched on, and certainly in the previous session as well, that when people wait, this can exacerbate the existing condition. The early stats on the first slide, around the 4 million of the 15 million having a comorbid mental health condition alongside their long-term health condition. In those cases in particular, you know, the client suffers twofold: on the physical health side, where they have to wait, as well as the psychological well-being side. So we know the problem isn't going to go away, and waiting can only exacerbate existing problems. Next slide, please. So nobody wants to wait. Nobody wants to wait for treatment. We know, and the data is very, very clear, that, you know, good mental health shows improvement when people's physical health improves, and vice versa. So there's a very big case, even for those people who have physical health conditions and the comorbidity. We need to help them on both domains. Certainly offering depression and anxiety interventions for people, particularly whilst they're on a wait list, has also been shown to be very, very fruitful too, as it gives people something to work on and starts to kind of socialize them as to what, you know, what's to come into the therapy. And the fact that they can actually start to put, you know, key therapeutic techniques based around CT for depression and anxiety into practice also kind of helps facilitate kind of a shorter lead time when it comes to actually having therapy delivered, and often requiring, certainly some of our research that we've published, around kind of 2 to 2.5 fewer sessions with a therapist. So there's an added benefit there of having people prepare for therapy. And finally, these programs can actually be tailored. So something like Silver Cloud isn't a one size fits all. It's very much tailored to the actual individual and their presenting problem. And certainly those people with long-term conditions, Silver Cloud has very specific programs around that are tailored to people with cardiovascular disease, tailored for people who have chronic pain, long-term chronic pain conditions, also diabetes as well, and various lung conditions as well. So there's a great synergy, as I said, there you cannot separate out kind of the physical from the mental, and it's really important that in the debate, in the conversation around elective treatment, that mental health is kind of very much up there at the forefront, just alongside all the other ways that you're discussing within this event. So on that note, I'll kind of coming towards the end of the presentation. Next slide, please, is just at kind of the patient flow. So again, around data, we collect that data so we can identify who the right patient is and get them to the right treatment at the right time. And that's kind of primarily by having a digital front door. So making access to psychological therapy easier, where somebody can go online, find Silver Cloud, pick the right program for them and go through an online screening and triage process. This obviously allows services to meet the needs of clients right throughout kind of the spectrum of what they deliver. The fact that, you know, integrated tools within person mental health treatment provides that additional support to the clients that they need. And the most important thing I think to take right from the patient flow here is actually embedding these in the start of any pathways, be it mental or physical, to build resilience and improve outcomes. And the fact that it's digital, people have access to Silver Cloud post-intervention, post-treatment, which means they can actually follow up on everything that they've kind of covered in their program. Next slide, please. This just gives you a very kind of high level kind of overview of how a system could work, where kind of on the left you have somebody entering a digital flow. They are then kind of triaged through the system into either guided self-help or kind of at a step 2 in the middle, where it would be supported by a practitioner, be stepped up to a kind of higher level need of acuity. And they can then work through those treatment pathways, and they can be stepped up and stepped down very easily by services all the way through to discharge or kind of follow-on post-treatment services as well. Next slide, please. In terms of kind of the overall backlog, we have the challenge now whereby we know there's a unmet need and we need to meet this need, and digital tools provide that. So addressing that backlog, we've got staff support, which is absolutely crucial, provides preventative mental health at a very early stage within a patient's journey, children, young people services adopting digital, and then also our IAP services, and now moving digital tools into secondary care. And again, all of this is made available through kind of our digital platform, which is safe, secure. We have got an ebook you could download to look at how it can be used to reduce waiting times and kind of various assurances that, you know, you have through NHS Digital, NHS Apps Library around our security and governance. So thank you very much for having me here today. Really appreciate that, and I think, you know, if there's any questions or anything, happy to kind of take them in the remaining time.
Oh, you're welcome. Thank you very much, Mohammed. And that was absolutely fascinating. Thank you for taking it what Well can offer and how it can benefit patients across the NHS. It is now time for our final networking break, where you'll be able to connect with all the delegates who have joined us today. After the break, we'll be hearing from Ian Eardley and our final panel on patient flow. So I'll see you in 10 minutes.